How to use the Mini Mental State Examination, a guide and teaching resource for aged care service providers. In this, the final part of the four-part series, will cover using the results, including interpreting the results and practical implications. It should be noted that a score of less than 24 out of 30 or a marked decline from a previous score should prompt consideration of the need for medical review. The following can be used as a guide to assist with interpreting the Mini Mental State Examination score. A score of between 24 out of 30 is considered to be within normal range. From 20 to 23, mild cognitive impairment is suggested. A score of 10 to 19 is suggestive of moderate cognitive impairment, and a score of below 9 is suggestive of severe cognitive impairment. The guide will not be valid if the person tested displays difficulties or limiting factors due to poor English language skills, poor eyesight, hearing, acute ill health, pain, or the presence of a tremor. A decline in cognitive functioning has been found to occur with normal aging, and a potential best score for any individual is also related to the level of education achieved. As shown in this table, a person who achieved a 4th grade education only may be able to score at best 22 in their mid to late 50s, declining to a best possible score of 19 out of 30 over the age of 84. Whereas a person who achieved a college level of education may be able to achieve a best score of 29 out of 30 in their 50s, declining to 27 out of 30 in their late 80s as a normal process. The score obtained from the Mini Mental State Examination does not relate directly to the functional abilities of the person. People who score less than 20 may experience difficulties with managing finances, driving, shopping, preparing meals, and managing their medications, but may be able to manage other activities such as maintaining their hygiene, grooming, dressing, and eating. Cognitive and functional deficits may not be apparent to others at an early stage if the decline has occurred gradually over a number of years, particularly if there has been frequent contact with the person. Scores obtained on a Mini Mental State Examination may be higher or lower than the norm and not accurately reflect the level of impairment that a person may display in a functional sense. In dementia, people may not necessarily complain of memory difficulties. There may be a tendency to continue to try to get the right answer and be unperturbed by incorrect answers during the testing process. In people with Alzheimer's type dementia, usually the first deficit is in short-term memory or recall, as demonstrated by difficulty in recalling the 3 items in question 5. Disorientation to time is followed by disorientation to place, and language deficits start to appear later. In a vascular type dementia, the deficits are more patchy. People may have speech and language problems earlier than an Alzheimer type dementia. In delirium, clouding of consciousness may be apparent with difficulties in concentration and a tendency towards irritability during the testing process. It may be difficult to engage the person's attention to be able to complete formal testing. Visual hallucinations may be present. Fluctuating levels of consciousness and alertness may also be observed. It should be noted that the Mini Mental State Examination should be repeated once the delirium has resolved, as the score obtained while the person is delirious is not a true representation of their actual cognitive functioning. In depression, people are more likely to be concerned about their memory and to complain of a poor memory and concentration, but on formal testing they may not display these reported difficulties and may score within the normal range on Mini Mental State Examination. People with depression are more likely to take longer to respond to questions and may answer, "I don't know," or not attempt to answer. They may be concerned about their performance and incorrect answers, or give up on a task. In general conversation, they they may not display obvious short-term memory loss or word-finding difficulties. Practical implications. In completing the mini mental state examination, the person being tested provides information that can assist with planning care. Some examples include: if the person displayed difficulties in following a three-stage command, as in question 8, then strategies that break down commands into single steps are likely to be more successful than providing the person with a series of instructions at the beginning of a task. Difficulties in the area of orientation to time, as in question 1, may prompt a review of the guides to orientation, calendars, clocks, etc. that are available within the person's immediate environment. A person's inability to comprehend a written command, as in question 9, may justify a review of the communication strategies that are in use. In summary, the mini mental state examination is a well-established, fast and reliable way of gauging cognitive functioning. Attention to preparation and adherence to the guidelines for scoring can greatly enhance the usefulness of the results. The score obtained can assist with diagnosis. The process of undertaking the mini mental state examination can identify health issues and provide information useful to planning care. Other parts in this 4-part series include: what is the mini mental state examination, undertaking the mini mental state examination, scoring, and this final part, using the results.